Okay, here's the restart. The characteristics of a dilated cardiomyopathy is the myocardial fibers become inflamed and they rapidly degenerate. Associated with that, you have cardiomegaly, systolic impairment. These patients have very low ejection fractions. They have systolic impairment. They have chamber enlargement, ventricular and atrial. Because of the cardiomegaly, the low ejection fraction, there's stasis of blood in the left ventricle, and so there's the potential for thrombus formation. Cardiomyopathy can develop very acutely or can be insidious. The symptoms are going to be the same as for heart failure. Here you've got a heart that just doesn't work. Here's an example of systole and diastole in a normal heart. Systole, contraction, diastole, relaxation. Look how dilated this heart is. It's very congested. During systole, it doesn't move much. During diastole, it's all stretched out. What do we do for these folks? Well, we control heart failure symptoms. That's a palliative process. You treat the underlying disease processes. Sometimes they'll do the intermittent inotropic infusions, followed by very aggressive diuresis. This has a very, very poor prognosis. It generally progresses to the point where the patient either needs a heart transplant or they're going to die. Heart failure without dilated cardiomyopathy is much better to manage than is dilated cardiomyopathy. That's probably the worst heart condition that you can have. 50% of all transplants are for dilated cardiomyopathy. Okay, the second kind of cardiomyopathy is hypertrophic. It can be caused by aortic stenosis or hypertension, but at least 50% of the time there's a genetic component. It's an inherited situation. These are the young kids, athletes often, that have sudden cardiac arrest, oftentimes in the middle of their exercise or their basketball game or something like that. Here you have hypertrophy of the heart muscle, but you don't have ventricular dilation. So it causes the ventricle to get stiff and small. It's more common in men than women. It's diagnosed in young athletic men, typically. It used to be called, and this is what I was stumbling over in class today, it used to be called idiopathic hypertrophic subaortic stenosis. And, IHSS, when you take these words apart, kind of can help make sense of what's going on here, and I'll do that for you in a bit. It can cause a severe outflow obstruction. That would be the subaortic, below the aorta. Stenosis is referring to an outflow obstruction. Not all hypertrophic cardiomyopathies produce obstruction, okay? But when they do, they're particularly problematic. When a patient has hypertrophic cardiomyopathy, there's four main characteristics. They have massive LV hypertrophy. They have very rapid, forceful contractions of the left ventricle. Their heart does not relax. And in some patients, they will have obstruction to the aortic outflow. So the blood has a hard time getting out. Here is systole and diastole in a normal heart. Here is systole and diastole in a hypertrophic heart. Now what I want you to notice is when this heart is contracting, that blood is trying to get out of the aorta here. But look what happens. The contraction happens here, right? And the blood is kind of pushing up against the valve. It doesn't make this, keep pushing on that, sorry. It doesn't make this turn very well to get out of the aorta. And then here it is during relaxation. You can see during relaxation you still have a very small chamber compared to the normal chamber. This is a autopsy picture of a very hypertrophied left ventricle. You can see how small the space is for that blood to collect. Your manifestations, a lot of times the patient doesn't have any symptoms and then suddenly they die. If they do have symptoms, it's exertional dyspnea, fatigue, chest pain, syncope, and rhythm disturbances. They can have supraventricular tachycardias. That just means fast heart rates that are originating above the level of the AV node, so somewhere in the atria. Atrial fibrillation. They can also have ventricular tachycardia, and then they can have a sudden cardiac death due to ventricular fibrillation. What do? Well, the goal is going to be to improve ventricular filling by reducing the contractility of the left ventricle and by relieving that outflow obstruction. Beta blockers can be used to reduce the contractility. Remember that beta blockers are negative inotropes. They decrease the force of contraction. They also decrease heart rate. Calcium channel blockers. These will help with reducing ventricular contractility and will help with decreasing heart rate as well. Same goals. RV pacing. Pacing the ventricle from the apex, that's the point of the right ventricle, will allow the septum to get depolarized first. So it allows the septum to kind of move away from the left ventricular wall and helps with that outflow obstruction. If you can get the septum to move over, then when the ventricle kind of contracts together, the blood gets out better. So that's the point of RV pacing. The patient may very well get a cardiodefibrillator for potential ventricular dysrhythmias. And then they may do surgery to help take out some of that muscle, especially the septal area. A ventricular myotomy, that has to do with the ventricle. Myotomy is an opening into there, and then they will do a myectomy where they take out some of the heart muscle. A septal ablation can be done, and what that is, the patient goes to cardiac cath, and they actually put alcohol, absolute alcohol, into the first septal artery off of the left anterior descending. So they go up the femoral artery, through the groin, femoral artery, up the aorta, all the way to the aortic valve. Then they go into the coronary artery, left main, left anterior descending, and they find the septal artery. They inject that with alcohol, and it causes the septal wall to infarct. So they're on purpose producing a heart attack that will allow some of that heart muscle to die. Imagine that. The results take about 3 months because you got to have, the inflammatory response has to come clean up this necrotic tissue. It takes the improved heart failure symptoms and the ability of that patient to do better exercise. It takes about 3 months to get good results. Now restrictive, this is the least common kind of cardiomyopathy. Etiology, pathophysiology is kind of unknown, but anything that can cause inflammation, fibrosis, sarcoidosis, radiation of the thorax can injure that heart muscle and cause it to become stiff and rigid. Diastolic filling and ventricular stretch are impaired, so this is a stiff ventricle. Systolic function is not affected, so the heart can have its systole, but it has systole of less volume. I'm going to go ahead and stop here. I have to do this in 10-minute intervals.